Later date. However, during the question and answer, you'll have the opportunity to turn your mic and camera on. Oh, sorry, could we go back to that slide? Thank you. The recording will be stopped and not capture the camera audio of attendees who speak if you are going to make a comment. And any open discussions towards the end, which I'll come to when it comes to the agenda, won't be recorded either. And that's to allow everybody to have candid discussions if they wish, without it being recorded. This is just our agenda. I'm going to do a more formal introduction to the programme just in a second. So first up, we'll have Daniela Latina, who works with us at Healthcare Improvement Scotland as a social researcher, presenting about her research on maintaining compassion. There'll be an opportunity for open discussion after that. We'll then be hearing from Eileen McKenna from Royal College of Nursing, and hearing about compassion fatigue from a staff perspective, particularly nursing staff. And there'll be an opportunity for question and answers at the end. I just want to say, thank you again for everybody coming. A lot really of maintaining compassion, things like compassion fatigue, which we'll hear a lot more about, are quite focused on the frontline clinicians, and nursing staff and doctors in particular, and a lot of the research is focused on them. And again, Eileen will be presenting from a Royal College of Nursing perspective, but we're aware that it has the potential to impact all health and social care staff. And we've got such a diverse group here within the clinical network, which we really welcome. And we would really welcome all of your contributions to add to our knowledge of how this manifests and impacts, particularly with mental health and substance use in the context of caregiving. So thank you all for being here. I also, in terms of that, compassion should run through every level of health and social care, not just the frontline clinicians and individuals. It should be at every level at managerial levels of all tiers and all the way up to the health board. I will stop there. If I've missed anything, Benj, please come in and prompt, and we will get started. So thank you everyone for being here.
Thank you, Champreet. Hi everyone, my name is Daniela Latina. I'm a social researcher at Health Improvement Scotland. I work in the mental health and substance use team at the moment and have done a bit of desk research on maintaining compassion. Connie, if you could go to the outline of the presentation, please. Thank you. So I'll be speaking a bit about this before we have Eileen, and the outline will include what the definition of compassion fatigue is, the risk factors that can impact on people, the impact on people receiving care, the impact on staff, the notion of it being affiliated with burnout. Is this actually the same thing, or is there an overlap and connectingness but a difference there? Some mitigations and remedies that have been proposed by researchers and also the NHS themselves, and then just a wellbeing hub resource slide in case anyone isn't aware of some of the help that's out there. Thanks, Connie. So there was a researcher, Charles Figley, and he famously referred to trauma experienced by staff mainly as the cost of caring. He looked at therapists and he said that when they were working with people with trauma, what happened was the cost of caring ensued because they also became traumatized due to the deep physical, emotional and spiritual exhaustion that came from day-to-day working in such an intense environment. Thanks, Connie. So consistent with that, this idea of a diminished ability to have compassion for others. That's kind of consistent with the most current use of the term. It's defined as a formal caregiver's reduced capacity in being empathic. And this is also deemed as quite a natural consequence in behaviour, as opposed to something that could be prevented, that it's this kind of manifestation. This is linked to the idea of burnout, so that cumulative a sense of fatigue or dissatisfaction, and then also the idea of the secondary or vicarious trauma. Day and Anderson looked at this more recently than Figley, and they again concluded that it was a consequence of working with victims of trauma or illness. Next slide, please, Connie. Thank you. So there's many risk factors, and this isn't all of them. This was just a quick overview for the presentation. Previous research tends to support the hypothesized relationship between the risk factors that may increase compassion fatigue and psychological distress and burnout. So there's like the occupational setting, so people that are working in occupations that are crisis presentation prevalent, and also places like inpatient settings and crisis teams. So there's a repetition of that daily. Also the organisational and job related factors. So not only the occupation setting, but the environment as well. So when you have patient contact, there may be an inability to have the right medication there or equipment, or have enough time to spend with them. And there's also these other factors like accountability and the amount of administration people have to go through as well. Again, the environments we are very familiar with, I think, at the moment, with things like increasing demand and expectations, and this is alongside the reduced capacity because of things like demand and expectations and staffing levels. So again, the onus is on the individual usually to respond physiologically and psychologically. Personal experience can also impact risk. So if a person has a history of trauma, low social support, even something like gender can contribute to aspects of risk. For example, one study found that female psychologists and violence counsellors who had a high percentage of sexual violence victims as clients reported to have more second-hand trauma, and this was related to greater psychological problems when they reported burnout, and that was as recent as 2021. Next slide, please, Connie. Thank you. So, as well as the impact on staff, which is great, there's also an impact on people receiving care. So there was a Johns Hopkins study that found that 74% of healthcare providers showed no compassion for patients due to various reasons. And what they found is when the relationship was beneficial between doctor and patient, there was actually an adherence in medication of 34% increase, which demonstrated if there's good relationships there, the patient is more likely to interact with their medication and their treatment. Another impact on people receiving care is the self-care. Then on the opposite side of that, if they've not got that good relationship, it could impact health outcomes, and there's definitely more research required on patients. Next slide, please, Connie. So the impact on staff, which we'll probably know about. Stephen Trzeciak, who we're going to see a clip of in a sec, had a study. He has a book called Compassionomics, and he's looked at this quite a lot. He said that with staff, there's a parasympathetic response, so they have difficulty relaxing, somatization, psychological distress, and that can present physically. Psychological well-being can be impacted, so chronic stress and anxiety. There's a reduced ability to self-care, reduced sense of purpose, and low morale and job satisfaction. And this leads to like absenteeism and recruitment and retention problems. And Connie's just going to show a little clip just now.
But research shows there's a compassion crisis there too. A recent Harvard Medical School study found that 46% of Americans believe that our healthcare system and our healthcare providers are not compassionate. Numerous scientific studies have shown that physicians miss the vast majority of opportunities to respond to patients with compassion, and compassion comprises less than 1% of all physician communications with patients. Recent data from the Mayo Clinic shows that half of healthcare workers are so burned out that they're suffering from depersonalization, which is an inability to make a personal connection. And perhaps the most concerning for the future, a recent survey study found that almost 2/3 of physicians and nurses have observed a decline in compassionate care over time, specifically over the past 5 years. Based on all of these data, I conclude we have a compassion crisis indeed.
Thanks, Connie. I should say there's a bit that it doesn't go on about there, but what he found is that the compassion intervention study that he's talking about, the intervention to be compassionate would take around about approximately 40 seconds. So that was an interesting study. Connie, could you go to the next slide, please? Thank you. There was a more recent study, it was qualitative, that was shared in one of the clinical networks that Champre is part of, and I read the paper and thought it was quite interesting, and it's quite the same, like what Steve Trzeciak's saying about it's not burnout but a normal reaction to an uncongenial workplace. So this study explored patient-facing healthcare staff perspectives of stress and burnout, and they used a qualitative strategy. I just thought that was quite insightful because a lot of time burnout and compassion fatigue can be measured quantitatively, and sometimes that doesn't explore people's actual experience. It can just be yes or no questions or scales, which is great to have big data and numbers, but if it's qualitative, you can get in depth and understand it a bit more. So this study, the self-reported stress reaction to the uncongenial workplace, was mainly attributed to staff to provide the quality of care they felt was necessary. They felt that they were unable to do that. The burnout that they felt manifested as long-term physical fatigue, stress and anxiety. They also felt that there was a hierarchical positioning in workplaces, so patient-facing roles in the middle of the hierarchy, and felt like they didn't have as much autonomy. And the large amounts of responsibility, the lower the autonomy went. It also found that occupational approaches definitely need to have more focus in the workplace as a social detriment of health. Thanks, Connie. This is another clip from Steve Trzeciak about compassionomics, and then I think there's one about burnout as well.
But what about time? We've all heard the expression, time is money, but time is also a vital factor in the efficiency and the economics of healthcare. So here's a staggering number, 56. Research from Harvard University shows that 56% of physicians believe they do not have time for compassion. This is in the context of a classic study from Princeton University on helping behaviors, which found that it wasn't the intrinsic belief of the importance of helping by the potential helper. It was whether or not the potential helper believed they had enough time to help. So a couple of years ago, after nearly 20 years of working in the ICU and meeting people on the worst day of their life, I came to a stark realization. I had almost every symptom of burnout. And let me assure you, that's not a good place to be. It can be a dark place. Currently, the recommended prescription for burnout is what I call escapism. Get away, detach, pull back, go on some nature hikes or whatever. But I was not buying it because I believed that the antidote to burnout had to be at the point of care, in personal connection, human connection, not a
Thanks, Connie. You can go on to the next slide. But I think what Steve was saying, he actually spoke at Health Improvement Scotland in 2021, but he's a bit busier these days, doing lots of talks and writing books. There's lots of different things about him online, and he does talk about that it's not that there's people don't have compassion or there's a lack of it, it's actually that they don't have time and other things to, there's other aspects that impact it. And as he's saying there about going hikes, there's nothing wrong with individual agency and going a walk or those things he's saying as escapism, but it's instead of just looking at the individual agency, we have to look at the structures as well. So these mitigations and remedies, on the left-hand side, it was a systematic review from Marshman et al. In 2021, and they suggested that mitigations would be necessary for mental health nurses, including strong leadership, positive workplace cultures, clinical supervision, reflection, self-care and personal well-being. And then the study I spoke about, the qualitative study was similar, and it said, you know, having audits, service improvement initiatives, improving access to information, leadership's responses to concerns, and addressing workplace stressors were all necessary in mitigating these circumstances. Thanks, Connie. So then we've got individual recommendations as well. He's probably familiar with these. These are from the NHS, and there is the acknowledgement there that compassion fatigue can be a common experience in caring professions and can cause all these things like tiredness, trouble sleeping, feeling hopeless and isolated, and irritability. What the NHS suggests is look for these signs if you aren't already, and hit reset. So just basic things like water, good food, sunlight, exercise, and just watch out for not great coping mechanisms like eating too much or drinking alcohol or anything to deal with stress. And just cut yourself slack, leave work at work or leave work at the door, get support when you need it and the way you need it. So just remembering that everyone's different, so they might not have great family or friendship groups, they might need to speak to someone like a coach, and let other people show compassion to you. And then they also have the checklist, and that's on the next slide, please, Connie. I'm sure we've all seen this as well. It's about when you're going home, just to think about these things, and I think you'll be familiar with them, most people here anyway. So it doesn't mean that you switch off from today's event, so just have these, and if this checklist doesn't work for you, maybe edit it to suit your own needs, and just go through that checklist when you're going home, if you can, hopefully. That's next slide, Connie. These are just some sources of health and care well-being that we have access to NHS. So just in case anyone wasn't familiar with these, we've put them on the presentation as well. Thanks, Connie. And now we're going to go over to an open discussion about how these factors of compassion fatigue might resonate with you and talk about your experiences. So I think we might start recording.
The Royal College of Nursing. She's the Associate Director for Nursing Policy and Professional Practice, and we are really honoured to have her here to speak to her, to speak to us about her experiences and give her presentation. So thank you, Eileen.
Hello?
We can hear you.
Right.
See you. I can see you. Yep, and hear you.
Right. I couldn't get my camera off, sorry. So thank you so much for inviting me to speak today. I'm going to just go over a bit of the background around compassion fatigue, give you a sort of summary of what the RCN has provided to members around support for compassion fatigue, and then go through some data that we have around the experience of nurses in general across Scotland. So first slide, Connie. So you've already heard that FIGLE has done a lot of research, and the definition around compassion fatigue refers to an identifiable set of negative psychological symptoms that caregivers experience as a result of providing care while being exposed to either primary trauma, i.e. experience the trauma firsthand, or secondary trauma, rendering care to those who are experiencing trauma. Next slide. The RCN's work, and I've just given a sort of brief overview of the work that we've done around compassion fatigue. The RCNI actually own a number of the nursing journals, and there's been numerous published articles in our journals from 2007 onwards. In 2018, the Cost of Caring was an RCN bulletin, and that highlighted the experience of an RCN member who experienced compassion fatigue and went on to write about self-care and she now provides training on emotional resilience. RCN Congress was in Glasgow in 2022, and there was an item for discussion that the meeting of our RCN Congress discuss if there should be increased awareness of compassion fatigue, and ultimately the response was yes, there should, and how it not only impacts on the delivery of patient care, but how it's impacted by leadership within the workforce. The RCN has a number of resources, including mental health and wellbeing resources that members can access, but members can also access a counselling service. We also have promoting healthy workplace, healthy you resources to employers. Next slide. This slide really builds on what was discussed earlier in terms of the two components of compassion fatigue, and this one's from a model that was an author who wrote about compassion fatigue in nursing. However, FIGLE argues that when our job is to help others who are in distress or traumatised, we must adopt the perspective of the person to empathise with them, and by doing that we expose ourselves to negative emotional energy and trauma, and it can lead to what's called secondary traumatic stress. Over time we can also experience burnout and feel as though our helping work is not having a positive impact. So why do we continue to do compassionate work if there's a cost on us as individuals? According to STAM, we do it for compassion satisfaction, which is the yellow circle that you can't really read on the slide. That is the positive experience of helping others. And when you speak to nurses about what brought them into nursing, the majority of the answer is to make a difference. And so I think that links to that sort of compassion satisfaction. Compassion satisfaction and compassion fatigue can run hand in hand, but it's when compassion fatigue overrides that satisfaction that you begin to experience the symptoms. And as we know, nursing requires huge amounts of compassion and empathy to support individuals in whatever care setting. And although it can be extremely rewarding, it can also be very costly and emotionally demanding. One study found that the greater the distance between the care nurses were able to provide and the care they were aiming to provide has that negative impact, along with other physical and emotional stressors. Work-life balance, colleague support and acknowledgement from leaders and managers were some of the factors that help reduce and lower level compassion fatigue. And conversely, lower levels of manager support have predicted higher levels of burnout and compassion fatigue. Next slide. So what do nurses in Scotland say? So we carry out a last shift survey, that's easy to say, every 2 years. So our last survey was in 2022, and I've pulled out sort of the key findings for Scotland. So nearly 90% of our respondents said the number of nursing staff on their last shift was not sufficient to meet all the needs of patients and service users, and less than a quarter of shifts had the planned number of registered nurses working, and that was the lowest out of any of the other countries of the United Kingdom. And next slide. So nearly 70% of staff working in Scotland feel that patient care was compromised on their last shift due to staffing levels, and that's well above the UK average of 62%. And only 60% agree that they had enough time to provide the level of care they would like. Next slide. Staff in Scotland were also most likely to state that during their last shift they felt exhausted and negative, with 63% agreeing with the statement compared to the rest of the UK, which was 54%. Next slide. So the key findings that staff are at risk of burnout by covering gaps in the workforce. Around 2/3 were unable to take their breaks and 62% worked additional time during their last shift. So you can see here there's a correlation to what was discussed earlier of some of the causes of compassion fatigue. Next slide. So along with our surveys, we have what we call the SenseMaker tool, which aims to capture the lived experience of nurses. In Scotland, we, along with our colleagues in Northern Ireland, have been using this tool since the beginning of the pandemic. So it gave us a historical record of the lived experience of nurses during the pandemic. We've recently refreshed the tool to reflect and working with nurses across the country to determine the questions that are built into the tool. And we've refreshed the tool and it's now a UK-wide tool. What I've done here is pull out the most recent data from the Scottish responses. So the tool captures both qualitative and quantitative data. So respondents are asked to share a story, and then they're asked a number of questions that are based on what we call these triads. So they're asked what was most valued within their story by the organisation, and you can see from the respondents in Scotland, quality of care was there, but most of the respondents felt what was most valued by their organisation was the cost of care. Next slide. The pressure source that links to their stories, again, you can see quite clearly by the heat map that organisational priorities were the pressure source for nurses who were responding. Patient care was a bit of a pressure source, sorry, that's my nursing language coming out, a pressure source, and less so the team. I have to say, I've compared the Scottish heat maps with the rest of the other 3 countries of the UK, and we don't come out well in terms of nurses' lived experience at the moment. And I think this story kind of highlights the impact of organisational priorities, particularly the sort of bottom half, those stressors showing teamwork on the wards, the snippy, nasty, feral fight to survive every shift, the pressure to kick out patients who still need to be in hospital to bring new patients in, or the inability to organise support to facilitate a patient discharge. And that's quite a common theme from the stories, is not only the relationships within the team and how they can be broken down, and not necessarily their direct team, but the other teams across the floor, so sort of relationships between A&E and receiving wards, etc., etc. And some of the themes that we've picked out are not only just compassion fatigue, but that moral injury and moral distress and the impact it is having on nurses' well-being. Next slide. So what are they having to compromise on? And you can say, are they compromising on staying true to their values, or their physical and mental well-being, or patient safety? You can see there's a spread across all 3, with a heat map in the middle. So that's basically those respondents are saying that they've had to compromise on all 3 of these things. But the biggest heat map is around the physical and mental well-being. And again, a story sort of saying, overworked and undervalued is a constant feeling for myself. I spend work life feeling stressed and under pressure. I never thought I would ever feel like nursing wasn't for me. But since the pandemic, I just want to leave. And they feel that they do 2, maybe 3 people's job, and they feel overwhelmed. And again, that's like a common story. Next slide. So when overwhelmed, what are they expected to do? And you can see that like the heat map's pretty concentrated around push on and address the problem later. Then the respondents feel they are not supported to take a step back from the source of the stress, or even seek out support from others. So we've lots of resources about wellbeing and support, both within within my organisation, but within the NHS and other care settings. But that message clearly isn't getting through or translated to nurses, who feel that they've just got to push on and address the problem later. We also believe that the focus on individual resilience, and I personally believe resilience has become weaponised against nurses, that if you're not coping, or if you say you're not coping, one of the responses is, well, you're maybe not as resilient as others. So it's definitely become weaponised. Next slide. So what was missing for them? And this is a theme that comes out time and time again. What was missing? A bit of doing my job well, not working as part of a team. And in fact, one of the themes is that the support that they get from each other within their individual teams really has a positive effect on their experience. But feeling valued and respected is missing, and that's not just been feeling valued and respected by the government, or it is clearly right through the system. And they say they don't feel valued by the government, their organisation, their managers, or even sometimes the public. So it's a strong theme. Next slide. When you look at resources for managing compassion fatigue, a lot of it puts the onus on the individual. And I have to put my hand up and say, my own organisation, when I was looking at what resources they have, or the 5 things that you can do to reduce compassion fatigue, the onus was on the individual. Many of these things come out, prioritise self-care, take breaks, find a hobby. And even one of them said, tidy up your life, make sure. And I just think we're kind of missing the point here. So next slide. The RCN commissioned the King's Fund to do a report on what supports nurses and midwives to deliver high quality of care. And this report was published in 2020. It's called The Courage of Compassion. If you read this report, there's nothing in here that is new. There's been years of evidence base around what it needs to be in place for nurses and midwives to be supported to deliver high quality care and feel that they have the time to do the job to the level that they come to work to do the job to, but also feel supported in the work environment. And the Courage of Compassion breaks that down into an A, B, and C. So having autonomy, control over one work's life, and that's linked to authority, empowerment, and influence. And there's been lots of studies around that structural and psychological empowerment, or the lack of it, within the nursing profession. And that's international, not just working in the NHS in Scotland. That justice and fairness, feeling psychologically safe. And again, a lot of the stories from SenseMaker are about people not feeling psychologically safe to raise concerns or issues, or even, you know, put their head above the parapet, because the message is just get on and you know, don't make a fuss, just get on and do it. Working conditions and working schedules. Belonging, the need to feel connected and cared for, and team working is a strong theme. And again, as I said, through SenseMaker, team working, and that positive, when teams are working well, the positive impact that has on people feeling supported. And culture and leadership. Lots and lots of international evidence around the impact of poor cultures and leadership, not only on patient outcomes, and I think, you know, there have been many stories or examples across the UK around poor culture and leadership. You know, we can go back as far as mid-staffs, etc., and that you know, culture was one of the key issues. And contribution, the need to experience effectiveness in work and deliver valued outcomes back to making a difference. You know, having a workload that enables the sustainable leadership and delivery of safe, compassionate care. Management and supervision, having time to reflect, mentorship, clinical supervision, etc., things that you've all talked about earlier, and being supported for continuing education, learning and development. Next slide. So where are we? There's an opportunity. The RCN, as part of our recent Pay Talks campaign with Scottish Government, we didn't just push for more money, but we did, and we worked really hard. Well, I didn't, because I don't do that work. That's my ERD colleagues. But we highlighted the feedback that we were getting from nurses, students, healthcare support workers across Scotland. We also have published this year our second state of the nursing workforce in Scotland. So we secured a commitment from the Cabinet Secretary at the time, who's now First Minister, for a ministerial nursing and midwifery task force, which aim is to build a sustainable and skilled workforce. There's 5 working groups that are feeding into that task force. There's the attraction, and that's about recruitment and retention and how we make nursing and midwifery an attractive career option, because we will never improve things, either patient care or the lived experience of nurses, if we can't attract people and retain people in the profession. I actually co-chair that subgroup with Claire Pearson, the nurse director in Tayside. Culture and leadership, again, a key issue, and ongoing education and development. And well-being is the final sort of subgroup, looking at what we can do to improve nurses and midwives' well-being. There's lots of work. Professor Richard Kyle did work in Scotland around nurses' well-being and found that nurses have poorer health outcomes than the general population in Scotland. That's a low bar. And that's not about individual choices. That's about the impact of their working environments. There's a listening project, and for the nurses in the room, I would urge you to get involved in the listening project. This is your opportunity to shape the profession as it moves forward. Next slide. I think that's actually me finished. So happy to take questions, and I'm going to try and paste the link for SenseMaker in the chat.
you.